My voice is back. I just tested it out for about 2 hours teaching
Well,
a
well,
resident.
good.
I was concerned that the laryngitis was going to be a problem for my echo present.
Oh no. Well, it sounds perfect, I think. So, well, it is
So
12 o'clock.
so that's
Um,
good. So my voice is good right now.
yes, I think you're
Perfect.
perfect. So it's 12 o'clock. We'll go ahead and get started. I'm sure more people will start trickling in as well. So, good afternoon, everybody, and thank you for joining us. This series was created to support clinicians with continuing education, telementoring, and collaboration opportunities to increase quality of care and support for persons living with dementia and their caregivers in rural communities. Today's presentation, Risk Reduction Strategies, is brought to you by Dr. John Culberson. He is professor of family and community medicine and Mittemeyer Endowed Chair for Medical Excellence in Geriatric Medicine at Texas Tech University Health Sciences Center. Before we dive in, we want to take a moment to recognize the organizations that have made today's presentation possible. So we'd like to thank DSHS um, and F. Marie Hall Institute for Rural and Community Health at Texas Tech University Health Sciences Center in partnership with the Garrison Institute on Aging.
I need about the last 10 days.
One moment. Okay. Before we begin, we'd like to take a quick roll call. So if everybody could please drop your name and your organization into the chat. Let us know where you're from. And then again, I did include the pre-series survey. So if today is your first session, please make sure that you get that completed. And in the chat, you will also find the CME handout for today's session. And it has like all the instructions of what you need to do to claim the credits as well. And then also just some housekeeping items. Just make sure to mute your microphones. There will be an opportunity for questions at the end, and so we'll open the floor at that time, and you can unmute yourselves and ask questions. With that, Dr. Culberson, I will let you take it over.
So I'm assuming I'm going to see the PowerPoint pop up.
Yes, I can share it for you. One moment.
Okay, so I'll just get started by telling you that my experience with older adults with um, cognitive problems started when I was in 10th grade, actually, where my dad told me that I had just got me a job at a nursing home, and he wanted to see if I really wanted to be a doctor or not. So that was an experience that really was just amazing as far as I was concerned. It was the best job I've ever had, and I and I and I really got the feeling of what it's like to be a professional caregiver. And once I chose family medicine as my focus during medical school and beyond, I then stayed on and became a geriatrician because I really found it to be very rewarding to care for older people. I am not an expert at dementia any more than I'm an expert at geriatrics in general. And I think they all obviously have some crossover. However, I think today's presentation, I'm going to give you my quick 15 minute. Um, I think that's what I'm supposed to limit it to, just for the kind of some factual information about individuals with dementia and their families and how we can help them. I'm going to steer pretty clear of some of the more challenging issues, which really comes down to the fact that there's a lot of different opinions out there, and there's no real clear answer to simple questions like what causes dementia and how you fix it. It's not quite that easy. And so I'm going to focus on what I do best, which is how you help families to come to grips with a really life challenge. And so I think this is going to be a little bit interesting because my case has a lot of writing in it, and I thought we were going to kind of talk about each particular slide as they came by. Rachel, can you make that happen, or do we have to go through all the slides and then just have a big old conversation?
I think I can go through each slide.
Because and I think it'll be better because that's the way it unraveled, the case unraveled in a very segmental fashion. So let's go ahead and talk a little bit about how you can protect people from dementia, or at the very least slow their progression of the disease, and in the meantime not um, forgetting that they have other medical problems that need to be addressed as well. Um, this is something that it's hard to do, but when you have a patient who clearly appears to have some memory problems, and family members come and bring them to your clinic and want to know if they have dementia or Alzheimer's disease, or what they is this going to be, can we fix this? And really what you should tell them during the time of their initial visit is that it's a chronic, progressive, and fatal disease. I have to admit that I have trouble saying the fatal part of it, but that's just the fact. It's not something that to this date we've been able to identify the causes and come up with solutions to keep the progression to at least a minimum, if not to completely stop the disease in the beginning. I know I was at an American Geriatric Society meeting, and the president um, gave his gavel to the next president. He got 10 or 15 minutes to talk, and he said, if you had told him 20 years ago that we were not going to have a cure for this disease, he would have been shocked. And he said, it's time for us to take care of people who have the disease, not try to come up with ways to help slow the disease down or prevent it completely. And I think that just comes down to the fact that the best scientists in the world are having trouble figuring out the best way to go about this. And so we'll just include that as part of our discussion here. Alzheimer's disease in particular is a cognitive disorder, and everyone really thinks about memory for the right in the beginning. Um, Not understanding that actually memory problems in older people, it does not necessarily mean you have dementia. If you hadn't had a good night's sleep, or you're stressed out, or you have depression, or even worse, if you have other disease processes going on, your memory could be affected pretty easily by other diagnoses. Behavior is also something that as people get older, um, their relationships and their ability to function as efficiently as they used to when they were younger. And I say this as a 66-year-old man, and I'm not happy about it, but I have to admit, um, we're starting a new electronic medical record, and I'm having a lot of trouble getting this down. Just not as quick at learning things as I used to be. And that doesn't mean I have dementia. It just means I'm frustrated about it. And as the disease progresses, certainly the behaviors become more obvious and more difficult to treat. The function is really the best thing to kind of focus on, because function is it's pretty objective. It's not subjective, it's objective. People are not able to do things that they need to be able to do to be independent. And we'll talk a little bit more about that after we go back to the original screening tests for potential cases of Alzheimer's disease. And I picked the MoCA exam because it's got the most advantages to it. It's also a little bit more difficult which we'll talk about in a second. Um, but remember, these are screening tests. These are not diagnoses. You really should avoid, many times we avoid doing the testing in the first visit just so we can get to know each other and um, take a good history and physical exam to kind of get us on the right track to what the family's concerns and needs are. Because frankly, if you put an older adult into an exam room and close the door, and they're in there with their husband or wife or daughter or son, there's a lot of pressure on that, and they really we know people have some people are good at taking tests and some people are not good at taking tests. And this gets amplified by the stress that's in the room. And again, we'll come back with stress later, but really it's not easy to just do one of these screens and get a score and say, this means that you have this. And that's why I kind of like mild cognitive impairment anyway as an initial diagnosis. I'm not saying that you should keep it at mild cognitive impairment if it's not appropriate. But a MOCA score um, below 26 out of 30, it has a good series of different types of questions, and it's actually these screening tests are like the MMSE and the slums, and so there's some others, but they really do um, try to carve out certain questions or for certain different types of effects that a cognitive impairment disease such as Alzheimer's disease give, and they tried to make it you able to reading the results of the screening test, you could determine what aspects of the disease are present, and therefore, whether it's Alzheimer's disease or some other type of dementing illness. And that's getting a little bit out of our league, I believe. I don't think that's helping anyone to try to make diagnoses based on these screening tests. If your score is close to 26, but not quite 26, you could tell people that there does seem to be some impairment. It could be due to their stress in the test taking, the screening test taking period there, or it could be a something called mild cognitive impairment, which is actually a pre-dementia stage, which really could be caused by sleep apnea or, as I said, depression, stress. And so you need to be careful about jumping to the Alzheimer's disease, because then you're going to have to go through that chronic progressive fatal thing. And that's really not good to start off with for a new patient that's scared, his family's scared. And so it's really nice to be able to call it a mild cognitive impairment. And frankly, it's pretty interesting because a third of the people actually will go on and have chronic disease of the Alzheimer's type or other types, particularly vascular dementia is pretty common. And so many people that have dementias have multiple different types of disease. And of course, if you were in medical school, that's one of the test questions they usually give. Parkinson's disease itself can cause dementia, and Lewy body dementia is a form of that kind of disease. But there's all sorts. I think there's 150 different types of dementia, and so it's up to the neurologist if you really want to know exactly what's going on. I just don't think that helps sometimes. And so, at least in the initial stages, being able to say that a third of the people who have mild cognitive impairment will go on to have Alzheimer's disease, if that's what we're screening for. A third are stable and they'll continue right where they are now, whether what their problems had to do with a difficulty getting a good score on a test. We all know medical students and probably physicians in general are not immune to that kind of pressure. Last time I took the American Board of Family Medicine exam, I think I was a little bit nervous about it. Um, but it's also completely reversible in 33% who have the problems I mentioned before and have experienced a recent loss, or in fact, I'm glad that they're coming along with sleep medicine because I believe a lot of people are having problems with uh, not only um, sleep apnea, but actually um, difficulty getting a good night's rest because they have pain in their back or they wake up and they have to go to the bathroom 3 times a night because they've got BPH. There's a whole lot of reasons why people don't get enough sleep. And then depression, more than just the loss, the depression of having leave your home of many years after losing a loved spouse and having to go live in a foreign town with your daughter or son, and the feeling of grief that they have to experience with just the fact that they're going to be a burden. And that is the kind of thing I'm going to focus on today, actually. We'll go through some other things here because we all know that there's certain medications that are supposed to help, and they do help. But in people who have either no dementia or or no memory problems and are just um, in your in your exam room and someone says, oh, this is what she's doing or he's doing, he must have dementia, let's give him some medications for it. And there's really not much evidence that people that have mild cognitive impairment or no impairment at all, which is the way they're going nationally, they're looking for biomarkers so that they can start to treat people who don't even have any symptoms yet. And I suspect these drugs, the cholinesterase inhibitors and DA inhibitors, notice, Rachel, I'm not using brand names. I think I'm not supposed to do that. So I left it this as these groups, and they do help. But many times I believe a lot of the help that's given to patients with early dementing symptoms and potentially a um, mild cognitive impairment diagnosis really are um, have some placebo effect. The cholinesterase inhibitors in particular do tend to um, increase your activity levels a little bit because of their their cholinergic inhibitor aspects, and that makes them more alert and oriented and they more engaged with you. And so the family will often come back and say, oh, the medicine worked really well. It helped them a lot. And honestly, these medications are supposed to slow the progression, not treat symptoms necessarily. And so I just want to warn you about that because those are the two most common uses on the market. The memantine or the CM, I guess memantine is a generic name, I think. It's I don't get myself in trouble here. They do tend to, in nursing home settings, get a little bit more down on the behavior aspects, and they do seem to work, and so that's supposed to be reserved for people who have moderate or severe dementia, and most of those individuals are pretty clearly having problems, and the behaviors. When we go down to the next set, um, redirection versus medications. In the long-term care isn't the only place where redirection can occur. We've had a fairly good success with our local um, caregiver support groups, which come out of um, the, the the School of Medicine and their efforts to help people. And we'll talk in a minute about the fact that some people can stay at home and have there's a new trend and aging in place, and you need to support the home the home environment and the caregivers in particular, particularly family caregivers rather than. But I want to warn you that on the street, the point is that you really shouldn't be calling husbands and wives and children caregivers. They're husbands, wives, and family members, and that's really important to everyone, I think. Um, but really the caregivers can be professional, and they have some really good ideas out there, such as social day centers, where you can go to work and you drop your loved one off at the day center, just like a children's care center. And having experience of having a wife that's taught in 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 daycare facilities for a long time and having two little granddaughters there now, they're loving it there. They just love being around other people, and it makes a big difference. COVID took a big shot on all these things, and they went out of business, and so they haven't really gotten back together. Long-term care memory units, I'm not going to focus on this at all because really once people get to the long-term care setting, it's really a different ball game, and the people that are primary care for those individuals are in fact long-term care physicians and nurse practitioners and things like that. But I think that it's important to know that those memory units focus on very, very structured, community ordered or oriented activities. And if I'm having a bad day in the nursing home, I just go over to the long-term care memory units and interact with the patients in there. And it is very uplifting. They're much different than people who are isolated in their home. And so I think while it's not the ultimate location of people with end stage dementia, does have some advantages to some people. So, okay, Rachel, the next. Okay, so here are the risk factors, and this is probably what I was supposed to be talking about, but um, I promise to stay on track here. The age and the family history, and I'm just going to take this minute to say there is a lot of stuff out there. If it's not on social media, it's AI in action, and they are putting stuff out there for people who don't have a medical background. And they're saying that we were fooled all along because people are saying that this is an age-related illness, and it's not. If you have honey, cinnamon, and a special ingredient that you probably have in other words, they're selling stuff that has nothing to do with medical treatment of this disease. And ever since COVID, I've noticed even the research projects are getting more and more scanned, um, with good data that has large and, is very carefully planned, and they aren't overstating the hypothesis and the conclusion of the research. But I will say that dementia of any kind, in my opinion, I'm going to say this because I know the neurologists are much more on top of this than I am, but that it is not well understood, and it's going back to, the brain is the what 3 pound universe. It's not easy to figure out what's going on in there, even though they have made incredible progress and they've got some new medications, which we'll touch on briefly. Um, if you head trauma, all right, many patients will tell you no, they didn't play football in the NFL for 20 seasons, or they didn't crash their motorcycle or anything like that. Head trauma can be pretty simple, and you may not even know you had it. But that's a good reason to wear a helmet, I guess, and not be a football professional. But I don't think once it's done, it's done. And it does have a very, very strong influence there. I mean, I think the head injury people, especially if they go on to having post-concussion syndrome and not stop doing what they were doing in the first place, um, cardiovascular disease is some very, very well educated and skilled physicians can really tell you that, and my my boss when I was first getting started felt that ischemia from cardiovascular disease in general was a very important aspect of most cases of Alzheimer's disease. Now I know the Alzheimer's disease people are helping to fund this exercise, but it's not clear to anyone really exactly why some people get disease like this. It's inflammatory, and again, many people as they get older start not being as physically active because they have arthritis and things like that. So the best treatment for inflammation appears to be exercise, and so they're behind the eight ball there. It's hard to do that. Diet certainly plays a part, sugar in particular. So I really do focus on teaching my patients that kind of attitude to, just try to get up and move in your walker and work those muscles because muscle mass makes a difference in the inflammation levels. And so all this is aside from the normal treatments that they're planning in the future to hopefully put an end to the disease in general, but at the very least slowing its progression. Um, Medications are we're the American Geriatrics Association was trying to figure out how to give themselves what do we do that other people don't do, and they have a four M's is what it's called, and many of you have probably heard of this. But the four M's are matters most, meaning make sure you let the patient tell you what they want, even if they're not without memory problems and they have an MPOA and everything else, they still have an opinion, and it's really important to listen to them. They will feel heard, and their their challenges with their disease will actually improve if you give them an opportunity to discuss. That's kind of my claim to fame in the clinic is I let plenty of patients that have at least moderate or severe dementia talk to me in clinic. I ask them questions and they answer me. And I've had numerous family members say that I was the first doctor that ever did that. And I know we're kind of crunched for time, but I think it makes a big difference. Medications are pretty obviously a problem. The specialists are just following their protocols. But when people get on 20, 30 medications at a time, there's going to be side effects, and it's not going to be helpful to people with cognitive impairment. Um, Caregiver burnout is what the case is going to be about, so I'm not going to really get into that too much. But these people are working hard, and their success is paramount to what's plan B for your loved one if you are just getting so burned out you can't really. And transference, I know that's a psychiatric diagnosis, but if you're burned out and you are short on things, you're not sleeping at night, it's probably going to kind of wear off on your loved one who you're the caregiver for. So sometimes it's nice to have multiple caregivers, some professionals, some multiple family members, but that's not the way our society's set up right now. So there's plenty of good caregiver organizations that can come in and give you a break, and that's almost, in my opinion, the most important treatment you can give people with dementia that are living in their home. Um, the memory unit and the retirement community has some advantages because you get to know a lot of people during your time in the independent living where you get to know all these people and you eat meals together, you go on trips together, everything's, and then one after another. And I can just summarize when my mom spent 8 years in the memory unit, not only were they smart enough to make her the chief assistant director of nursing because she was a nurse and they knew she would love that, which she did. In my opinion, the best 8 years of her life because she didn't have me or my brother and sister as kids causing problems, and she didn't have my father, the surgeon, causing problems. So she was out on her own there. But when she passed away, my son looked around and saw 200 people at her memorial service and said, "Wow, Grandma had a lot of friends." And I'm going to have to pause for a second because that was one of the most important things that happened in my whole life. Um, Next slide, Rachel. Okay, so I got ahead of myself. I was busy doing other things, but I don't think this is much different. So we can finish this in a minute or so. Um, Again, there's a lot of, we'll skip the first two because we kind of already did that. Please be very quick to point out that if you don't get a living will and a medical power of attorney in writing before the individual becomes not able to make decisions, official, formal decisions, um, good luck with that. It's so much better to have it done and just have those discussions with your family members. And they're not going to do it without your recommendations. I make a big deal about this too because it brings everyone together and they find out that their mother or father is not even concerned about this. They know because there's been lots of their friends that have gone through it and they want to be ready when it happens. If it, hopefully it won't happen, but it does. Mobility, as I said, we talked about ambulating and staying, increasing your muscle mass and loosening the joints. But did we mention that you don't want to fall? And falls occur in people that are not mobile, don't do anything, and especially if they have diabetes or some other form of illness that causes multimorbidity and can cause them to fall. It's actually the statistics are pretty bad for someone who has moderate dementia, falls, and has been sitting around. Their life expectancy is not going to be very long, and it's nice to be able to tell family members that in advance so that they can help get their loved one to use the assistive device. I got stories about my dad who had Parkinson's disease, and they're funny, but I'm not going to have time to give them to you now. In other words, they really don't think they need assistive devices, but they do. Um, Chronic disease it can is just really a big mess because we don't know how to prioritize this disease over that disease, and it just makes this very difficult. And those of you that are primary care providers know what I'm talking about here, and that is that it's really hard to manage all these diseases. And they go to see the specialists who do their protocol and are very good. And I'm very happy we have good specialists, but the bottom line is the family wants to know what's going on, and it's the harder it gets harder and harder with more multimorbidity. Um, and they even have dementia and depression in there because we sometimes don't really ask the right questions. And there are plenty of adults who have even moderate cognitive impairment who they can just pull the wool over your eyes. They sure don't sound demented, and they are. And so it's the rule of thumb is never, ever use a discussion with a patient as being a diagnostic tool because they will, especially extroverts, will really know how to change the subject. I like to say they're like politicians. You ask them a question and they give you an answer to a question you didn't ask. So, all right, Rachel, let's get to the case. So we can. Oh, I didn't realize I had another page here. Let's go to the case. I was going to shout out to our friends at the Garrison Institute of Aging who have actually received funding from the federal government for the GUIDE program. The guide stands for staying aging in place with your caregivers and basically paying a good sum of money to keep people out of the nursing homes, to keep people out of the hospital, and doing all those things. And it's a good program. It's just starting up. Who knows what CMS is going to pull out with this? But they're dedicated to their cause and they're trying to expand these programs, but it's very new, only a couple years old. It's kind of like the PACE programs are for the independent, you know, community-based day facilities, and that just it gets them out of the house, it gets them engaged with new people. And as I said, it's probably one of the more important quote drugs you could give someone at this point. Hospice, I had to put this down there. Hospice has a very high success rate in helping people who finally get to the point where they really, the family's like, look, we need to do something here. And they have specific qualifying factors for Alzheimer's disease. And my experience with our staff here in Lubbock is that hospice care and dementia, remember, it's got the word fatal in the end. And these individuals are professionals and they do wonderful work in the final stages. And they can get you approved by using things like went to the hospital 3 times last week. And that counts, and that's important thing to mention here. So, all right. Sorry, Rachel. All right, so I'm gonna let you read this. I'm not gonna read to you, and then I can just throw out one question per case, and we'll get through them pretty quickly, I think.
Okay. So a 75-year-old woman is
Oh,
seen
you're
in,
gonna read it? Okay.
what you said, I'm going to read it.
Okay. No, I was gonna give the participants an opportunity to read, but because they can do it.
Does anybody want to read this?
No, I meant just look at the thing and read it,
Okay.
Rachel, because it'll be faster that way. Okay, that's probably enough time because they were reading the whole time we were talking. But anyway, this is a true case. I picked it because first of all, it's a pharmacist, and secondly, she has some problems, but he doesn't want a screening exam or medication for the dementia. So why exactly is he here? And this is the kind of thing that you're going to see, and it's actually easier because he's already got himself lined up for what's coming, and he just wants to know what I think is best as the professional family caregiver, which is what he is technically, what he should do to help her. So he's already diagnosing her with dementia. What would you do in this case? What would you be your first, anyone from the, if you want, we can just go through these and get to the end, but so no one's stepping forward. So why don't we just say, I'll interpret what I was hoping to get to the discussion, and then we'll get through it and we'll go to the next discussion. As I said, he's a professional. He lives alone with his wife, far away from any other family members. And she's the one who went to see her mother and said that she seems like she might have some problems with her memory. And he was, okay, she told me to go to the doctor and ask a question, but he's the one that's in charge and he's already telling us what he will and won't do. That's fairly common. And at this stage, it's not a problem at all. So next slide, you'll be happy to see this. So she does get irritable when he pays the bills, administers his medicines, cooks the meals, and does all that kind of stuff. And then the horror of being helped in and out of your bathtub by your husband. So she was not happy about what was going on in her house. So we went right to the activities of daily living because that's more involved than just diagnosing dementia. It comes out to trying to keep her safe in her home, which is for someone that has early dementia, you want to make sure they're not going to get hurt, and that just is going to accelerate all the effects of their disease. Um, but look at this. She went out and ate meals 3 days a week. I don't know if I put that in here, but it was 3 days a week with her friends. And they went out and she loved that. Um, and her husband always said she was doing well. And she was unfortunately waking up at 4 a.m., which she's not this is not although sleep disorder is clearly a part of the diagnosis of Alzheimer's disease. There's a lot of other reasons why people wake up at 4 a.m. I'm on my third day straight between the call pager and my wife thinking that the dog had a heart attack, which was a false alarm, luckily. I've been up a lot early every day and I can't get back to sleep, is my point. So they're not getting enough sleep, which isn't helping her any. And then, as I said, her mother did not appear to be did appear to be more confused than on previous visits. That's what her daughter said. But her husband was very, very overprotective. And the whole point here is I called the daughter. I wanted to make sure she got a say in what she felt was going on, because just making a diagnosis and giving people medication often results in a lot of it's almost like scare tactics. And that's, I'm sure some people would say, well, that's what they need. But I try to ease into this. That's really an important thing. Yeah, and they are decide diagnosing early may not be dementia. And that was some of my slides earlier pointed that out. And it could be a lot of reasons, even a stroke or something like that, which I didn't put on the list. So, all right, next. So they came back and her husband actually was saying that this is really hard. I'm having a lot of trouble with this. But he didn't want to screen. And honestly, at this point, a screening test is not what she needed. It's pretty clear she has dementia. That's what the screening test is for. He also didn't let me take labs until this visit. I, I was not happy about that, but I respected his concern for finding things out. I think that's what he was in denial. He's not the first person. He won't be the last person. My sister, the nurse, and me, the board certified geriatrician, were in denial about my mom. So it can happen to anyone. But really, she didn't really seem depressed to me at all. And she's very good at talking. So still didn't look like she had early dementia, or maybe she did. And I knew she did, but I didn't really want to, focus on that at this point. She had all of her stuff and she's been eating well. Um, her she had test results were totally normal. I could have ordered some other tests, which I probably did, and I just didn't put it on this thing. But thyroid is something that I think you would probably automatically jump to. Um, but look at what happened. COVID came to town and locked them in their home day and night for 6 months, probably. Not only that, but three of her friends passed away due to COVID, and she was locked in her home. That is an exceedingly stressful situation, and which is why her 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 consistent socialization was nil anymore, and um, she really became weak because she was just sitting around, and she fell. and broke her femur. So that was while she was entering the bathtub. Her husband was weakened from literally years of caring, or at least a year. So next case, I spoke to the daughter again because she had been visiting and said, my dad is like really weak and not able to do much of anything. I don't know what to do because mom needs help. And so that this point she had already broken her leg. So she went to the hospital where they treated her appropriately. They put a rod in her leg, and that was what she needed for her injury. And then she was evaluated by PT, who said she needed skilled nursing facility, which was pretty obvious. But unfortunately, she was having delirium symptoms in the hospital. Another way of just being pretty suspicious. This woman has dementia. And delirium, remember, is a not a consistent downward trend, but a acute onset due to various things, including pain, surgery, just being alone in the hospital where you don't know what's going on, the dark room, the nurses come over, and it can be treated. But when you do treatments like hospitals typically do, an antidepressant, an antipsychotic medication, even if it is low dose, and hydrocodone, which she needed for pain control, these can trigger delirium. One thing that I just want to mention is we have a help program here, which is a American Geriatric Society sponsored way, and we have undergraduate students from Texas Tech University who get very good training through the hospital system, and they show up and they sit there with the patients who are at high risk of delirium, and they have done miracles. And it's just my observation that the young people are medicine for every old person that I've seen. They really love to sit there and tell stories about their past and ask them questions about their families and everything else. But this woman came over to the skilled nursing facility with delirium, and that was a problem because they didn't want the memory units are typically um, the most highly staffed. And so they said, no, you need to be in the memory unit, at which time husband demanded that she be moved back to a standard skilled nursing bed. But basically he said, I'm not keeping her here. She's looking at her future. She's in there with all these people that have advanced dementia, and we're taking her home. Her family was also around, and they helped out his anger. They said, look, we can help you at home with her, and we'll have home health come. And guess what? It worked pretty well. Rachel. Okay. So again, I called the daughter and told her to make a 2-week follow-up because I didn't trust her husband. He was not happy with me because I actually was the medical director at the facility that made the decision she had to go to the memory unit. But he canceled my exam, but he came 4 weeks later and he was alone. She was visiting, and so her daughter was visiting, so she was at home, and he said he wanted to know what he could do to increase, her increase in cognitive impairment was rather rapid due to her situation at home and during COVID, and then her fractured leg. And so he finally admitted he was burned out. He never admitted it before this visit. And so really it was he was listening, and so rather than just demanding solutions for his problem. And I suggested professional caregivers give him a break and add some speech therapy. Remember, Alzheimer's disease is a language-based illness, actually. And so the speech therapist can really make a difference. And then, of course, the current home health regimen she needed, because if she became bedbound, it was going to be a rapid decline to the end. And so he still didn't really want to have her go anywhere. even though he was really burned out and on his own there during lots of times. But really, he was saying, no, she's walking with her walker and she's doing pretty well. So I said, come back in a month. So if you haven't seen a trend here, it's frequent visits as things kind of depending on what speed the decline is occurring, and continuity of care is absolutely essential. We've got plenty of residents, physicians who doing very well with their patients in this situation, and we really have to focus so hard on maintaining continuity with the young doctors because they have different rotations they have to go on and stuff. So I think this was the best thing. All right, Rachel, sorry, I'm looking at the clock here. There's not going to be a whole lot of questions unless I stop talking. Um, she came back and I couldn't believe, the nurses couldn't believe it. No one could believe how well she was doing after not taking any medications. Did you notice? She did not take any medications. We stopped the medications that are advertised on TV. Result, well, I'm not allowed to say, but they just did research and proved that one of the antipsychotic medications worked and got it approved for FDA approval for treatment of behaviors. Now, the nursing homes aren't allowed to use this stuff because they claim the physicians are drugging the patients down, which I don't tend to totally agree with, but at least partially agree with it. But she was not on any medicines. She certainly, let me just say, do not ever give someone with dementia or early dementia or even potential dementia a benzodiazepine to sleep. Benzodiazepines will just make the delirium intertwined with the slowly progressive disease of Alzheimer's disease, and they will deteriorate much faster. Um, Also, I read something somewhere, I really don't know what to believe and what not to believe, but that people that use sleeping medication, including benzodiazepines for anxious depression, there's all sorts of reasons why you might use it, but that does increase your risk of Alzheimer's disease. Just because I mentioned earlier that when I gave a medication that tended to kind of bring people a little bit more active and get them up and around and more participating than just sitting there looking out the window, their disease got better. And I think that's true for people who have not shown symptoms yet. And so be careful with sedative hypnotic medications. The hospital uses them all the time, and I know they have to keep these people safe, but she not only was doing better in my vision here, but she really impressed all the people that were treating her. And her daughter was so excited of being able to accompany her to this visit. The whole family was there together, and she'd already gone to lunch a couple times with her mother, and she was looking forward to meeting some friends again and going out and getting out of her house. She had gained weight, and she was quite ambulatory. Um, I put this up here because fast stage 6B is severe cognitive decline. And based on her ability to function, she was at stage 6B, which is very close to a hospice level. But she was so much happier and active. So she proved you can do this without medications and you get a result where the family is just head over heels for this. And this is not always the case. Yeah, I cherry picked a case that had a happy ending. Um, but I believe this can happen a lot. It's hard to be a very, very busy PCP who has patients like this who are going to ask a million questions. So yeah, I do get additional time because I'm board certified in geriatrics. And I could never do this much with a standard PCP schedule. But this is just as good. In this case, it was just as good as any medications I could have given her. Going back to, I have to mention this because people are going to ask about it. The new medications that are that are coming out, the infusion medications that require a lot of monitoring for side effects and a relatively sketchy, they're not promising results unless they work for the drug company. Um, but these medications are a good start, and I do believe that they are gonna come fast now. So don't take me as being the anti-medication guy. They just need to do a little bit more work. And another thing that should scare you is the whole concept of using biomarkers for people who have no symptoms and testing you at age 50 sounds a little scary to me because people are going to be very concerned that they just had a marker for dementia and they're only 50 years old. So I'm really pretty cautious about that. But she did very well in everything, and she was basically not on any medications other than her previous medications for hypertension um and diabetes. And I gave her some Tylenol because she did break her leg, and but that's all she needed. So, all right, we got 4 minutes. That's bad. That's not the way it's. My apologies.
You're
This is
perfect.
not the way it's supposed to work at APCO. So
You're
they're not
perfect.
going to invite me back. I can promise you that. But anyway, I'm just very, given my own personal family history and my experience as really a geriatrician, that's what I do as a member of the faculty here. And I teach so many residents and students that it was time for me to step up and help you guys. So I should ask questions, not you should ask questions, not listen to me go on
Yes.
and
If
on.
you have any questions, feel free to unmute yourself or put it in the chat as well.
So looks like you get another 4 minutes, or else everyone's left because they have to go to class.
We still have some people on. Yeah, I'm not seeing anything come through.
All right, let me just say this. I don't mind that, and I'm not just going to sit here and talk anymore. I am going to say that this is an issue that the physicians, the nurse practitioners, the nurses, and most people in the United States. I don't know about other countries. I had a resident that's from Colombia, and she hadn't seen her family for 5 years. So she went back, and she had one mission, and that was we took care of my grandmother until she was 100 years old, and she did not have a high quality of life. We need to stop thinking that just keeping someone alive is the way to go in my country. So she's going to go out. We don't really have a good handle on how to advise people to take care of this situation. Everyone's different. Every family is very different. And this case was one where we had a really stubborn, loving husband, and he didn't really want to play the game. He wanted to just keep doing what he's doing and help his wife have a very good life, but things went bad. And so how do you address these unexpected situations that can cause very traumatic situations in a family? I mean, everyone here has probably had enough experience with families to know that some of the families are pretty split down the middle and no one can agree on anything. And they start telling people what to do. Um, and I'm going to
We
visit my new grandson, and I'm gonna go and visit my children's grandparents because they're all alone, and some of their family members are pushing for him to put her in hospice. And I said, that's not your job to tell her that. I mean, she's got end stage dementia, but we need to work on this. So I, I made a promise not to say anything about that. That's not why I'm going there. And so when you see patients, that's not why you're seeing patients. You're not seeing patients to tell them what they need to do. And I'm sure you're not like that. But this is a disease. It's very difficult to, it's easy to tell. I mean, we got Dr. Santos there, the surgeon. He knows if you need to have an amputation BKA, you need to get a BKA. That's just, and you're not very, if you don't do it, it's not going to be good. In this case, it's you never know what's going to happen next, and so it's hard for physicians, I believe, especially with the current. It's hard for anyone. I mean, we've got great scientists here, and they all have their opinions, and they even put my name on a couple, a couple manuscripts. And honestly, I was interested in them, but I didn't really know enough about what was going on to be able to say this is this is what we do. But the drug companies are going to try to sell their product. We all know that, and so we need to protect our patients from things that are not to their advantage. Although you know, some of you might cringe about this because I did spend the whole time talking, but I am going to say that there's no doubt in my mind that the placebo effect is real. And I'm not going to call it a placebo effect if I spent literally hours talking to a family about what was going on and what could be done and what cannot be done and how they should best move forward. That is placebo effect to have someone tell you that you're on their team. And I know a lot of physicians are very good at this. And I must admit, if I only had 15 minutes, I don't think I'd be very good. I couldn't even do this in an hour for
Dr. Culberson, sorry to
they're
interrupt
all
you.
signed off, right?
We have two questions. We have one in the chat,
Oh,
and
great.
Dr. Santos has a question as well.
Okay.
Yeah, I will read the questions in the chat box as well, Dr. Culberson. But first, I would like to thank you for your presentation and for sharing the success story in this big net and also in this case study, and also sharing your personal story because that's very difficult and you're able to navigate that. And you mentioned about Colombia. I'm actually in Singapore recently, and apparently over there in Singapore. People with dementia, they will actually pay the family to take care of their, patients, which have a better outcome. Something that seemed like similar to the guides, that you mentioned a while ago. My first question is, how do you avail of the guide? How do you get enrolled on that one? And number two, there's a question here regarding, are there any guidelines for genetic testing?
Well, the guide program is pretty much up and running. It's slow starting, but and part of that is up to us as PCPs to actually tell them about it. And there's very few people that are going to argue with staying at home. That's we're not telling them to go to a nursing home memory unit or anything. And the Garrison Institute of Aging here in Lubbock is has received a permission basically to be involved in this. And they have a group of people who are setting up nursing for visits, psychology for follow-ups, and you are required to go to your PCP, I think, once a year, just to keep everyone honest here. But the thing is, it's all you have to do is the memory clinic is a good place to start. Here we have one, and there are not very many of them around, really. I'm not going to make a comment about just a visit to the neurologist because, like any other human or especially a physician, we have our own opinions on things and we aren't going to do anything but what we want to do. The guide program in the memory clinic is multidisciplinary. They have a geriatric psychiatrist. They have an excellent psychologist who's very good at this kind of thing. And then they have, I guess they have caregiver support and what's the a neurology physician, and they do a work um, basically looking at the big picture, and then they can recommend a guide program if they meet the criteria, which is pretty easy. It basically is that you live at home, you have dementia, and you have a caregiver for bonus points. The caregiver gets even more money because they want a caregiver to be a family member. But they will see people alone in home, I'm pretty sure. But the guide program is all through the memory clinic and the Garrison Institute of Aging. And most of the
That's great to
children,
know, Dr. Culberson, because we have a lot of, people here from the rural areas that, hey, how can we avail that? And apparently this is nationwide. So I
well,
put
and we are
the
not
link
doing
there.
very well. We are not doing very well here in Lubbock at the Texas Tech Health Science Center, who kind of sponsors the whole thing because the physicians don't think about it. We're at the stage now where we're trying to make sure everyone knows about this. Really, I'm really excited about the program. I wish I had more time. I would be more involved in it, but
That's the great thing about the Echo platform. I can attach a link to the program in the discussion. So I'll get that done for everybody who's
oh,
interested. But we have a few more minutes, just a couple more minutes. But so the last question is, are there any guidelines for the genetic testing?
actually, they're working feverishly to kind of come up with the best biomarker they can. I mean, I'm just personally, if you ask someone and they have a first degree relative that had Alzheimer's disease, um, the number is 50%. If they had an ApoE4 gene, 50% of those children are going to have Alzheimer's disease if they don't die before that. Um, that puts me in the club, actually. Um, I don't think there's any guidelines at all. I think anyone can get one of these biomarkers. It's just it may not be the best. That the future could hold several that are much more accurate. And because if you have a positive biomarker, you're going to have to spend the rest of your time without dementia worrying about the fact you might be getting dementia. And so that's something that I think is worth mentioning to any patient who would like to get the biomarker. I think many of them would say, no, no, I don't want to. I mean, I've got so many people that don't want to live to be 100. I said, well, why don't you want to live to be 100? Because I won't be, I'll be an invalid. And I said, well, no, there's plenty of people that are 100 that are invalids. So you really, it's kind of a counseling requirement in my book, to tell them the pros and cons of getting this. But if they come up with a really good one in the future, the answer to the question is, I think you can order it. Actually, I think we've had some visits by, there's a lot of other markers that are out there. The cancer markers are very come a long way. So it's going to do that. When I was talking about pre-disease markers, I just, I don't know, what are they really going to give people medications with no symptoms at age 40 just because their parents had dementia? These medications need to be better before you start just giving them out. They're expensive and they do have side effects. Um, I think for some people it's worth the risk, certainly. I would never tell someone, no, don't get that thing. But it's going to be, there is a downside to those biomarkers. Just wait a little while and they'll start coming out with studies that show that they're much better.
Well, Dr. Culberson, I was looking at the wrong time and we are a few
Oh
minutes
yeah.
over. So thank you so much for joining us today. I know you have a busy schedule. So everybody, I inserted the CME handout in the chat. So make sure to follow all the steps to claim the credits. And then please join us on February 25th. Dr. Singer from the Garrison Institute on Aging, he will be presenting at that time. So
do not miss that.
yeah.
Dr. Singer is not only very good at what he does, but he actually will be able to present this in true echo fashion, other than just. I guess it's the lack of
Yeah.
sleep. Maybe I have dementia. I don't know. I
Well,
had
thank you.
trouble controlling myself there. No,
Thank you
actually,
so
I'm
much.
very nervous because